Thank you, Chairperson, for the kind introduction. So after a very enlightening talk of Simon Haller, I'm going to tell you about the SGLT2 inhibitor therapy and its impact, or especially its expanding horizon in non-diabetic population, or you can say the benefits what we can get with SGLT2 inhibitor patient, those who are not having the diabetes. Not working? Okay. So if we talk about from sugar, when it comes to the system of our body, there has been a lot of things, a lot of milestones where we can say that fluorescein has been tested and discovered in the 19th century to the modern era of dapagliflozin and empagliflozin, where the SGLT2 development is being held finally, and it has reached to the finally 1980 to 1990 was the year when the identification of the SGLT protein for the first time has been done. In 2000, we could know about the selectivity of the SGLT2 inhibitors. 2012 and 2013, for the first time it has been approved for type 2 diabetes. In 2019 onward, it was the landmark heart failure and CKD trials which expanded the scope of this medication. Today, SGLT2 inhibitors are redefined as cardiorenal protectors rather than just glucose-lowering medications. So, what is the mechanism beyond glucose control? SGLT2 inhibitor act primarily at the kidney by inhibiting glucose and sodium reabsorption. The downstream effects are, it enhances the ketone utilization, especially the myocardial muscles, reduces oxidative stress and suppression of the fibrosis in the myocardium. It lowers the intraglomerular pressure, improves the oxygenation and anti-inflammatory and anti-fibrotic action in kidney. In liver, it reduces the gluconeogenesis and fat accumulation in blood vessels. It causes natriuresis, lower blood pressure, and improves the vascular stiffness. So heart failure with reduced ejection fraction in DAPA heart failure trial, dapagliflozin reduced the risk of the worsening of heart failure or cardiovascular death by 26%, regardless of the diabetes status. Similarly, in EMPEROR, reduced confirmed empagliflozin lowered cardiovascular mortality and heart failure hospitalization. Importantly, non-diabetic patients gained equal benefits, cementing the role of SGLT2 inhibitor as cornerstone of heart failure therapy. So breakthrough, the trial EMPEROR, which has been done in the preserved ejection fraction heart failure patient. First therapy to show outcome benefits in the heart failure preserved ejection fraction was SGLT2 inhibitor. Reduced composite CV death with reduction in the heart failure hospitalization was the impact and effect which has been having the relevance what observed in both diabetic and non-diabetic patients, that heart failure preserved ejection fraction previously considered untreatable now has a proven therapeutic option. The SGLT2 inhibitor offer cardiovascular benefit through various mechanisms. What the mechanism has already been described in various forums as well as in the previous slides also, like reducing inflammation, like reducing the cardiac fibrosis, reducing the oxidative stress. It also helps in improving the sympathetic nervous system by reducing the sympathetic overdrive, and when it acts on the kidney, it not only improves the kidney function but also improves the erythropoietin level, which helps in improving the hemoglobin status of the body, as well as diuresis and natriuresis also helps in reducing the blood pressure. The DAPA CKD trial enrolled CKD patient without diabetes. Dapagliflozin lowered the risk of the kidney failure, cardiovascular death, and heart failure hospitalization. Relative risk reduction was considered in non-diabetics, marking the first trial to confirm the renal protection independent of the glycemia, reducing 39% kidney failure and death. Works in non-diabetics also, and first renal outcome success was beyond diabetes. CKD, in the DAPA CKD trials, already it is done. EMPA's kidney highlights were over 6,000 CKD patients has been included. Empagliflozin reduced the CKD progression and cardiovascular death. Non-diabetic CKD patients benefited equally. Slower, the eGFR declined significantly compared with the placebo. This evidence repositions the SGLT2 inhibitor as renal drugs across the population. The mechanism of renal protection. Renal protection arises through reducing the intraglomerular pressure, restoring the tubuloglomerular feedback in its hemodynamic function. Metabolically, it helps in caloric loss, ketogenesis, improves oxygen efficiency. Cellularly, it activates the autophagy and AMPK SIRT1, suppresses the inflammation and fibrosis. Vascularly, it improves the endothelial function and lowers the arterial stiffness. So, mechanistic overview of the SGLT2 inhibitor in reducing the risk of CKD. SGLT2 inhibitors are known to reduce the oxidative stress, known to reduce the glycemic load. It helps in improving the reducing the kidney tissue damage or improving the acute kidney injury. It helps in chronic kidney disease also by supplying the efficient kidney fuel sources through the ATP when the free fatty acid oxidation and ketogenesis works for that. The overall benefits beyond the diabetes is reducing the heart failure hospitalization by 30%, reducing the cardiovascular death by 15 to 20%, reducing all-cause mortality in CKD cohorts. It improved symptoms and quality of life. These outcomes are independent of the blood glucose lowering, highlighting a pleiotropic mechanism of benefit. Hypertension and arrhythmia, when we talk about this, SGLT2 inhibitors lower the systolic and diastolic BP through natriuresis, through which it causes more of the sodium lost through the urine, improves the endothelial function. Arterial stiffness is reduced by this action of SGLT2 inhibitor. So by stabilizing the ion balance and reducing the myocardial stress, dapagliflozin and empagliflozin both decrease the risk of the atrial fibrillation and ventricular arrhythmias, including in patients those who are not having diabetes. If we talk about the non-alcoholic fatty liver disease, which is also known as the MASLD, the trial demonstrates improvement in liver fat content and fibrosis markers with dapagliflozin, empagliflozin and tofagliflozin. Mechanism include reduced gluconeogenesis, enhanced ketogenesis, improved adiponectin signaling and anti-inflammatory effect. Benefits extend to non-diabetic NAFLD population, suggesting a future hepatology role. So if we talk about the SGLT2 inhibitor in obesity and metabolic syndrome, it provides metabolic modest weight loss in non-diabetic individuals also. Reduction in visceral adiposity. It also improves in blood pressure and arterial stiffness is reduced with the action of the SGLT2 inhibitor. Favorable metabolic shifts from ketone utilization, more of the energy efficiency, even in the absence of the available glucose. Potential role in metabolic syndrome management. Combination with GLP-1 receptor agonists has wonderful additive benefits. Ongoing trials assessing the obesity indication, expanding relevance beyond diabetes to metabolic health, and future therapeutic positioning in obesity care is important to understand. Inflammation and endothelial protections has been improved by the SGLT2 inhibitor. It reduces inflammation, attenuates oxidative stress, improves vascular endothelial function, reduces sympathetic activation. Already it has all been described in the previous slide. But apart from that, evidence of the lower hsCRP, which is a marker of the inflammatory cytokine, role in improving the vascular stiffness and compliance, possible implication in atherosclerosis prevention, and expands use in non-diabetic cardiovascular prevention. So future directions could be, for the cardiovascular protection, this is the preferred drug could be for the hypertension management as well as the prevention of the hypertension, especially in the patient with diabetes. It can also help in reducing dementia, especially the vascular dementia. Helpful in obesity correction and prevention both. CKD combination like RAS blocker when they are combined with the endothelin blockers as well as with the SGLT2 inhibitors is perfect cardiovascular CKD protector. Cancer cachexia, it is being worked up with still in the experimental phase. So there are certain limitations also in the future directions for SGLT2 inhibitor. And what are those limitations? Most large trials focused on the type 2 diabetes, CKD and heart failure. They have got the limited data in broader non-diabetic population. Mechanism behind the pleiotropic benefits are still not fully understood. Some neutral or variable effects reported in arrhythmias and non-diabetic NAFLD. There are certain adverse effects like genitourinary infections, volume depletion, and rare ketoacidosis, which is seen in the elderly or CKD patient. Incomplete responses in high-risk subgroups like advanced CKD and severe heart failure, and long-term safety and durability of the benefit is still under the investigation. With these limitations, the future directions for the SGLT2 inhibitor are still quite encouraging. That guidelines shifts to the SGLT2 inhibitor. In 2019, we could see that diabetes was the only indication for the SGLT2 inhibitor. In 2021, we could see that heart failure with or without diabetes was the indication for the SGLT2 inhibitor. And in 2022, we know that CKD with the broader inclusion has been one of the indicators of the use for SGLT2 inhibitor. And in 2023-24, guidelines class 1 recommendations for the heart failure, CKD, irrespective of the diabetes is there or not. So clinical implication, SGLT2 no longer just anti-diabetic drugs. Cardiologists using as first line in heart failure patient, nephrologists prescribing for CKD progression and its prevention. Primary care adoption for high-risk patients, it improves the outcomes independent of the glycemia correction. Cost-effective in chronic disease management. Potential reduction in dialysis and transplant burden is one of the most important benefits what we could get out of this. Holistic benefit across multi-organ disease spectrum, and it redefines the chronic care strategy beyond diabetes. So concluding that SGLT2 inhibitor therapy expanded from diabetes to multi-system use. Now it has not been restricted to the patients with diabetes. Now it has been open for those who are not having the diabetes, but may be having compelling indications for the use of this wonderful drug. Strong evidence in the heart failure, may it be reduced ejection fraction or preserved ejection fraction, and CKD, irrespective of diabetes. Cardiovascular and renal benefits in non-diabetes established, it has been used and established. Mechanistic basis beyond glucose lowering validated. What is the problem? I don't know. Safe and well tolerated in broader population. There are the guidelines and real world data which support the widespread adoption. Emerging role in the obesity, hypertension, metabolic syndrome, representing a paradigm shift in chronic disease management, and of course it serves as a future cornerstone therapy beyond diabetes care. Thank you very much for your kind listening.
Thank